For those who are joining, these are some of the good habits when you are attending a webinar. For our interactive sessions, you should have a proper sign-in name. Okay, rather than we calling you like Samsung S5, Vivo 1912 and all. If your sign-in name identifies your name, that will be better for our interactive sessions. For those who are joining, these are some of the Anoop, we are muted.
You can continue. You can continue.
My voice is clear. There was some echo coming.
Yeah, it's absolutely perfect.
Okay. You can introduce and start. 7-4 now.
Yeah. So one change we are planning is like we'll be from tomorrow onwards. So tomorrow we don't have any class as of now. Like we are just planning. We will inform you by tomorrow early morning. So even if there is a class that will be starting at sharp 7, we will start broadcasting by about 6:55 and 7 sharp we will start. Okay, so you all will have to cooperate with that. And today we are having Chandrasekhar sir again, and today we have a like very important topic that is COPD ventilation. Just like ARDS ventilation also, knowing the basics of COPD ventilation and again fine-tuning in COPD ventilation is very, very important. And if you understand the concept about this autopy, like what is happening if there is a bronchoconstriction. So that concept, if you understand, then it is very easy to apply in your practice. So please listen to Dr. Chandrasekhar. I have listened his COPD talks at least two to three times before. I think one of the best I ever heard that. So please listen carefully. And if you have any doubt, go back and watch the video recordings once again. And in between, like if you are not having a COPD patient, at least monthly once you again come back to our YouTube and listen like what he has said. And that should be practiced in in your ICUs as well. So over to Dr. Chandrasekhar sir.
Thank you, Anoop. My slides are visible, Anoop?
Not yet, sir.
Okay.
Not yet.
Not yet?
Not yet, sir.
Share screen, sir, first.
Yeah.
Then open that.
Yes.
Yeah, now fine, sir.
Fine.
Yeah.
Good evening, friends. Yesterday's talk was about ARDS. Probably it was a bit long because ARDS ventilation is difficult to master and learn. So a lot of concepts have been introduced. Next Tuesday, we are going to have a whole session on only case and troubleshooting. All three of us will handle some three cases, and we will show you how to do the settings and what is the physiological basis, and then we'll try to make you apply the concepts you have learned. COPD ventilation also is important because COPD is more common than ARDS. You can say a lot of ICU admissions would be more in COPD numbers than if you look at the ARDS numbers. So yeah, COPD ventilation has some issues that it's a fixed disease. So disease modification with medical therapy may not be very robust like in treating a young guy with a pneumonia ARDS. But that should not prevent us from providing treatment, because we have seen over time if mechanical ventilation is done in a right way, patients do survive and live quite a few years from their discharge from the hospitals, sometimes probably with NIV also. But when a COPD patient comes, as a clinician, you should not think that it's not, what is the use? It's not going to be easy to treat. That should not be the attitude. As I've said yesterday, repeatedly I'm saying this, mechanical ventilation is not going to mitigate your disease process nor your bronchospasm. I've seen many of my junior colleagues saying that spasm has not gone, I've intubated. It doesn't go. It can't go. It goes only with your medical therapy. ventilation is going to try to support your heart, lung in the process of bringing down your PCO2 or improving your oxygenation so that the medical therapy works and the patient becomes all right. So when there is issue with bronchospasm, always think, what have I done everything medically correct, or are there any options like giving magnesium, maybe even in the rarest of rare cases, halothane, ketamine, things like that can be tried. But the mitigation of the disease and the bronchospasm definitely requires medical management. COPD is important, as I said, is because it's the fourth leading cause. It's expected to become the third, and it accounts to 6% of deaths globally. So we do get, in fact, in any ICU, if you go, there will be 2 to 3 COPD patients at any given point of time, isn't it? So this is very important that you learn how to ventilate COPD patients. Many patients suffer from the disease for a very long time and they die prematurely. And COPD will continue to increase because people are not going to stop smoking, and possibly because of the aging population. The incidence of COPD is going to increase. As I've said, COPD is a common and preventable and treatable disease. It can be prevented if you really talk to the patient and convince him to stop smoking. And once the disease is set in, you can treat it from getting worse. So it is a treatable disease. And what is the main characteristic is, these guys come with a persistent respiratory symptoms of cough, sputum production, and dyspnea. And the main pathological, as a clinician, to mechanical ventilation is expiratory airflow limitation. There is an expiratory airflow limitation. This may be due to airway or alveolar abnormalities. These are important. You just remember this. This is, as I said, caused by noxious particle or gases. And though COPD affects the lung, it has a lot of systemic consequences. This chronic inflammation in the lung becomes something like a chronic inflammatory syndrome. And these guys have a lot of weight loss, osteoporosis, cardiovascular diseases. Then they may have incidence of lung cancer. So we generally say COPD is a chronic inflammatory syndrome with a systemic consequences. As I've said, the young colleagues always think there are a lot of difficulties in ventilating COPD patients. Yes, there are some difficulties, but that can be overcome once you understand the pathological rationale of your ventilator setting. So ventilating a COPD patient is difficult because there may not be a reversible component, as I've said earlier, and these patients are difficult to wean. There are a lot of comorbidities and systemic effects, and quantifying auto-PEEP or dynamic hyperinflation at the bedside is sometimes difficult. So this makes mechanical ventilation in COPD quite a daunting task. But once you understand the rationale of what you have to do, most of the cases do well. So in the next 10-20 minutes, I'll try to make you understand the concept of dynamic auto. See, the whole concept is, once you understand why there is air trapping and how to identify it, what are the consequences of air trapping, and how to decrease that by your ventilator setting. Once you understand that, then ventilating is just putting numbers on a ventilator. That's not difficult at all. So I always believe, rather than teaching you the numbers, which if you don't understand the rationale behind, you won't have the conviction. Because we have been always taught that carbon dioxide is inversely proportional to minute ventilation. So obviously all of us, when we see increased PCO2, we tend to increase the rate and tidal volume. That has become our DNA. So to work and to convince you that's not the way to do is going to be a tough task. But I think at the end of my talk, I'll convince you number-wise, mathematically, and pathologically that doesn't always work. And most of the times it doesn't work. So there is a small airway disease. There is a damaged airways that easily collapse, and there is destruction of the parenchymal tissue, so loss of elasticity. So the air force to push out air is reduced. The amount of bronchitis to parenchymal or emphysema in different patients may be different. Some people may be more of a emphysematous and less of bronchitis, and some people may have a disease with more airway disease rather than a alveolar disease. That is a thing that you have to ascertain individually. So to understand, there is a bronchospasm, airway mucus production and inflammation. This leads to increased airway resistance, and the elastic recoil is reduced because the elasticity is lost because of the pathology. As I've said, the main pathology is expiratory flow limitation, which leads to increased functional residual capacity and a decreased inspiratory capacity. What it actually means, I'll show it to you in the next slide. You remember that the volume in the lung increases so that you don't have space for your tidal volume to get in and bring out the carbon dioxide. That is what means that there is a decreased inspiratory capacity. This leads to what we call as autopeak, and there is a diaphragmatic flattening, increased work of breathing. With this, there is an ineffective respiratory pump. So this leads to a respiratory failure. I would like to draw your attention here. The pathology is an expiratory flow limitation, but what happens is an inspiratory failure. That is the reason why we put them on a ventilator. Because I have told you on my first class, no conventional ventilator supports expiration, meaning no ventilator pulls air out. Though the pathology is in the expiratory flow limitation, because of atopy, decreased IC and diaphragmatic flattening, this goes into inspiratory failure, producing low tidal volume. As I've said, alveoli is a cul-de-sac. Once the volume increases, pressure increases. Once the pressure increases, patient has to increase his mouth pressure so that the flow goes into the alveoli. So he has to really push the air in. You would have seen with the pursued lips, using all the accessory muscles, they'll be trying to push the air in because the diaphragm also is flattened. So this leads to inspiratory respiratory failure, leading to low tidal volume and increased PaCO2. See, this is normal. If we have a FRC, tidal wall ventilation is occurring. This is the inspiratory capacity we have. And yesterday I told you 2.5 to 3 times is your FRC is your total lung capacity. What happens here is because of airway expiratory flow limitation, the alveoli starts becoming or accumulating more and more air. So what happens is your FRC goes up. Once the FRC goes up, your tidal ventilation is going to occur here. And the inspiratory capacity from here has been reduced to only this much. So to really understand, if I ask all of you to take a huge breath and then hold it and then take again another breath on that, is it possible? You just try once, all of you take a deep breath and try to breathe on that. It's so difficult, isn't it? That is how the COPD guys feel when they try to breathe, because the FRC is so huge and they're very close to the total lung capacity and the inspiratory capacity is very low. What it tells me is we don't have space for new tidal volume to get in to bring out the carbon dioxide. That is what is the bottom line. So that being the deduction now, obviously we have to put in a small tidal volume and breath rates of 12 to 14. I'll talk about breath rates in the later slide. So this much is clear now. Once the FRC increases, there is no inspiratory capacity. We don't have space in the lung because we are very close to the total. That's the physical limit of the lung. You can't push it beyond that. So another, as I've said, the diaphragm curvature is reduced. And second thing, what you have to understand is the requirement of oxygen. Normally around 5% of the cardiac output is the requirement for respiratory muscles. In a situation like this where the pump is very ineffective and because of increased PCO2, there is an increased drive. So the patient will be trying to push a lot of air and there is increased pressure in the alveoli. He has to work against a pressure, sometimes 10-15 centimeters. So the efficiency, the energetic investment prior to inspiratory flow is very high because of autopy. And added to this blood is acidotic, then hypercarbic and hypoxic. So the blood that is going into the respiratory muscles is not a good quality blood. All this leads to a kind of a situation where patient says, I can't breathe. So with the creeping hyperinflation, the lung and the chest wall lose their mechanical advantage. And inspiration insidiously becomes energetically inefficient. So that is what you have to understand. We are having hypoxia, hypercarbia, acidosis, and added to that, maybe at times 20 to 25% of your cardiac output is going to your respiratory muscles, because auto PEEP is a energetic investment prior to inspiratory flow. As I've said, alveoli is a Keldy slack. When you increase the volume, pressure increases, and the inspiratory flow occurs only when there is a pressure difference. To create a pressure difference, again you have to increase the capability of your respiratory pump to increase the pressure more than your alveolar pressure to push the volume in. So understanding this is something is counterintuitive, isn't it? We say apply PEEP in a COPD. Then I've already told you that the expiratory flow limitation is there, and then we are again saying that apply PEEP. So this let me explain to you in 2 slides. To what extent I'll be able to convince you guys, I don't know. But this is what is the hypothesis put in by Dr. J.J. Marini. He was a guy who coined the term auto PEEP. See, according to the waterfall theory, what he has proposed, he says PEEP is applied for decreasing the inspiratory effort. Here, you have to understand, we are not putting a PEEP to do anything to the expiration. We are just putting a PEEP to the aid the inspiratory effort. See, as you said, as you already know, as I've already said, if there is in a patient is in spontaneous breathing, and if he is contracting or trying to get this air out, he is going to have more pleural negative pressure. He's going for a forced expiration. In that situation, probably you may have more amount of pressure here, probably, and you may require little more PEEP than in a passive patient. So the bottom line, what I want you to understand is, in a passive patient, a PEEP of around 5-6 should be sufficient in a patient who is ventilated for COPD. In a patient who is breathing, around 6 to 8 centimeter, but rarely we have never used any PEEP more than 10 centimeters in a COPD patient. So how it works is like this. As the pressure starts deaccelerating as we come towards the alveoli, there is a point where we call it as a equal pressure point, or the closing point, where the pressure inside is less and this is more, and this is called the choke point. This is the pressure. This pressure is not now reflected as the alveolar pressure for us to push the air in. This is the choke point, and this is the pressure which we have to overcome. We don't have to overcome 15. That is what is proposed here. So this becomes your airway pressure. So you just put 5 centimeters, this will go. And as you already know, during expiration, this pressure is very, very high than this, and this pressure is not going to impact the expiratory outflow. This is what is being proposed. And this is the pressure that you have to consider. The choke point pressure is to consider. How to identify this choke point pressure, how much to give is what I'll be teaching you subsequently. But this is the proposed hypothesis, how PEEP works in a COPD patient. And this is being looked at in a waterfall background, in the sense that as long as your PEEP is less than this level, or if your water level doesn't rise beyond this, the water flow is never obstructed. Once the water flow here in the downstream goes beyond this, then this water flow is obstructed. That is how PEEP works. To bring this into clinically, how to understand, whenever you put PEEP like 5, 6, 7, 8, as long as your trans airway pressure, the difference between plateau and your peak and your plateau remains wide, that only the peak goes up, the plateau doesn't go. It is always thought that it is not going into the alveolar region. It is not going into the alveolar region. Now see 5, 6, again it is not gone. 7, see again it has not gone. Now I have increased to 8. Now see the plateau also has gone up along with the PEEP. Whenever the plateau goes along with the PEEP, this is the time when the set PEEP is crossing this limit, waterfall limit. So we generally tend to keep much less than that. I have put a numbers of 8. This is the normal maximum PEEP you would require to be ventilating in a patient with COPD. And this PEEP causes increase in plateau pressure and alveolar damage. So this is the point I'm trying to make you understand is when you start increasing PEEP in a passive patient who is being ventilated in a volume control, go from 5, check the plateau, 6, check the plateau, 7, check the plateau, at 8. At all these levels, the trans-airway pressure is wide. When you go to 8, the trans-airway pressure has come very, very small. That means the pressure has gone into, and the PEEP should be around 7 for this patient. That's what is the takeaway message from this slide.
Sir, can I just interrupt?
Yeah.
Many people are asking to repeat this one once again, especially the waterfall phenomenon and again the intrinsic PEEP concept.
See, it's counterintuitive to what we think. The patient already has an increased alveolar pressure. Then why do you want to set a pressure? We are setting a PEEP to decrease the inspiratory effort, not to obstruct the expiratory flow. That is the first thing you have to understand. Now, as the pressure starts coming down, as it passes through and there is a compression from outside, the pleural pressure, at some point, the airway pressure is being overtaken by the pleural pressure. We call this as the equal pressure point. Here, the airway collapses and prevents the outflow. Just this becomes the choke point. And this is the airway pressure that is reflected to us for inspiration, because there is a choke point here. And this pressure, if there were not to be a choke point, this would be reflected when there is no flow, and we might have to increase the pressure to minus 16 centimeters. But that doesn't happen because of the collapsibility of the airways, which normally would occur, would not occur in a normal patient. It occurs because there is increased collapsibility. This becomes our mouth pressure now. We just have to overcome this. And this is how we just keep around 5 or 6. 5, this is 6, just below this, if you overcome this, the inspiratory flow occurs. During expiration, it really doesn't matter because this is much, much smaller than this. And if you come here, it is if water at this level is like this, how is the water going to flow? This is much more than this. So water is going to stay back. This is what is called the waterfall analogy of PEEP setting. And that is reflected at the bedside for us by setting and looking at the peak and plateau. As long as the peak and plateau pressures are wide, your PEEP is not getting into this level. It is not getting into the alveolar level for our discussion, and that is reflected here. See, when I go from 7 to 8, my peak and plateau are very close. That means it has gone into my alveoli. That means it is hampering the flow during the expiration. This is the pressure which I don't want. I want to keep only supporting the inspiration, not obstructing the expiration. If I increase the pressures this way, probably it will cause the flow from decreasing. Don't go with the numbers I put there and numbers here. This is the numbers for this slide and that's a number for that slide. So generally when it would suffice for you to understand that when you put PEEP in a passive patient, always check for the plateau. When the plateau pressures go along with the peak, that is the time when your PEEP is harmful. Otherwise, it's not harmful, is the bottom line that you have to remember and understand. If any doubts are there, we'll come back at the end of the lecture. So this is what it means. When this goes up, the pressure is going and hitting the alveoli. And this is possible only when we do the pre-plat, and as I've said, pre-plat requires a passive patient and it can be only done in a passive patient. The other thing also, to look at the expiratory time, you can look at the expiratory constants, because there is where I discussed the expiratory time constants also in the webinar classroom. You can go and check it up. We will try to demonstrate this possibly. See, once the compliance and resistance are estimated, the time constant is nothing but a product of compliance and resistance. So once you know the compliance and resistance, now we know the time constant, which is 1.5 seconds. And we know that it requires 3 to 4 time constants for the lung to totally empty. Now we know 3 by 3 is 9 seconds. So if somebody has a high resistance, high compliance, probably in a combination, you may require a high expiratory time. This is another concept that is available on ventilators. We can try to integrate with your plateau pressure and try to set the expiratory time in a more scientific way. We will show you when we come to the discussion part. You just remember that you can estimate time constants by just the information that is available on the ventilator. And always secretion removal, bigger size tube, bronchodilator therapy, small things, but it makes a great difference in some patients. You always remember this. So now we have learned that there is increased air in the alveoli or air trapping or autopeep. Now we have to know how to identify and measure it. Then we should know what it causes to the patient and how to manage this. Once you understand these three concepts, then you will know how to set the ventilator. It's very, very easy. Once you don't understand, just go with the numbers. You will never be convinced. So in spontaneous patient and passive patients, what scalar is this? What scalar is this? There is a representation below the baseline. So this is a flow time scalar. Expiratory time is prolonged and it is not coming to the baseline. This is one which we have already shown. This is how you recognize autopeep in a spontaneously breathing patient, or you can, there are a lot of, if you, the amount of breaths is attempting or the clinically, it may be 30 on the ventilator, it may be 10. Whenever you see a patient doing that, you should presume there is autopeep. Then when there is unexplained tachycardia, hypotension, and clinical observation of an active expiration or a wheeze that continues on to the onset of inspiration in a spontaneously breathing patient, we should think that there is an autopeep. In a passive patient, this I've shown you yesterday or day before yesterday when I did my class on graphics. So you can put a expiratory hold. So the set peep has to be reduced to 0, and you do a expiratory hold for 3 to 5 seconds. Then if the pressure goes up, this is the amount of autopeep that we have. If you have an autopeep of 15, then you know the patient is very sick, or the airway collapsibility is very high. The autopeep is just 1 or 2, probably, you know, this is much easier to ventilate and wean and extubate the patient. So this also prognosticates, or once you do a bronchodilation and the next day with good medical therapy, which was 8, becomes 4, that means you know the primary disease is getting better. And another way of looking at it, the volume also can be done if you put a huge inspiratory hold for 30 to 50 seconds. See, whenever I say hold, it is obvious that it can be only done in a passive patient. It cannot be done in a spontaneous. You cannot say, tell to the patient, wait for next 30 seconds, don't breathe. It's not going to happen, especially a COPD patient. So it is obvious that it is only in patient who is passive, probably sedated or paralyzed. So if he was getting 300 ml, now he gets 700 ml totally. So about 400 ml of trapped volume has come. This also gives a clue what is the amount of autopeep. So what are the effects? Effects are hemodynamic compromise. Obviously, you intra lung. So it is going to decrease your venous return. It is going to decrease your venous return, and it is going to increase your afterload for the left ventricular contraction, then increased in pulmonary vascular resistance and carpulmonale. So these are the hemodynamic effects that can occur because of autopeep. Then increased work of breathing. As I have said that if the alveolar pressures are more, flow occurs only when there is a pressure difference. So you have to create, if there is 10, you have to create at least 12, 13 centimeters by using or recruiting all your inspiratory muscles. So that is the reason why patients find it so difficult to breathe. So increased work of breathing is there, and trigger have to cross the autopeep level before inspiration is initiated. So there are a lot of missed breaths. Any missed breath is a wasted effort. That means the diaphragm is contracting, but the ventilator is not supporting wasted breath. And studies have proved that the work done in a wasted breath is the work done for a triggered breath. That you have to remember. This I have already shown you. See, I have set a trigger of 1 centimeter, minus 1 centimeter as a pressure trigger. Patient has to cross the autopeep, then come centimeters. It is visible. Are visible?
Yes, sir, but you will have to repeat it once again. Your voice was breaking.
Yeah. it was showing unstable this thing. See, now if the patient has an auto PEEP of 5 centimeters and I have set it at -1 centimeters, patient has to cross this. The ventilator doesn't know, the baseline has shifted up. So he has to start and touch the point here, which is -6 centimeters. I have told you already in my previous classes, in a normal breathing, you require a transpulmonary pressure of just 5 centimeters. You don't require 6 centimeters. If somebody is required to do 6 centimeters, especially a COPD patient, lot of breaths are not triggered. See, this is not touched. Again, this is touching. So this is wasted work. So this can be overcome when you put PEEP. Probably this is what you overcome. This is what you overcome in the slide what I was showed with waterfall analogy. And one mode called NAVA doesn't trigger like this. It triggers by the electrical activity of the diaphragm. In a situation, if you have the facilities, if there are a lot of missed breaths, putting them on NAVA would bypass all these problems. When we come to advanced modes, I will show you and we will discuss with you what NAVA is. But NAVA is nothing other than pressure support being given according to the electrical activity or electrical signal strength of diaphragm. So the delivery is pressure support. There is nothing, this is not a new mode. We already know how pressure support works. So see here, so many missed breaths are there. See, all this is wasted work. This is flow versus time scalar. This is pressure scalar. See, there is a deflection, but there is no flow. There is a deflection, there is no flow. This is what is wasted breaths. So now going to auto PEEP management. See, there are only 3 factors that determine the auto PEEP management. One is minute ventilation. It doesn't matter whether it is from respiratory rate or tidal volume, IE ratio, and expiratory time constants. If you know, you can manipulate this better. Let us see how the interaction occurs now. So if PCO2 increases in COPD patient on a ventilator, what do? We increase the tidal volume and respiratory rate, because increased minute ventilation is what we have been taught repeatedly decreases the PCO2. Does it happen? Let us see. So this is what has been carbon dioxide removal is inversely proportional to minute ventilation. Minute ventilation is nothing but tidal volume into respiratory rate. God. See, if the patient, I had made, just a minute, give me time. My animation and all has gone. I had made the animations. I'll just come with you. Okay. See, what we generally see when we see a patient on a volume controlled with 400 ml, 5, and we do a AVG. AVG is 7.28, PaO2 is 70, PCO2 is 72. We have been taught that we have to increase the minute ventilation. What do? We increase this to 500 ml and 15 is the respiratory rate. Now what was 4 liters is around 7.5 liters, isn't it? The minute ventilation was 4 liters, has become 7.5 for 5 liters. And if you repeat a ABG after 2 hours, what has happened? Your pH has become 7.18, the PaO2 has become 65, and PCO2 has become 82. This is what happens. I'm very much sure this is what happens every time. So the question is, why this happens? See, we have been told, isn't it, that whenever there is a increase in PCO2, we have to increase the tidal volume and rate. But if you do a COPD patient, this is what will be the result. Time and again, you can go and check it up. This is what happens. Now, why does this happen? I think I'm opening some unanimated slides. I'll just give me a minute. I'll come back. Just give me a minute. Those animation slides have, I think, missed it somewhere.
You can take your time, sir. No problem.
Yeah. Because it becomes difficult for people to follow what I have in mind. Where is this slide which you are looking?
This concept should be very clear, friends. Like you should understand what is auto PEEP, how to.
Oh my God, something has gone wrong somewhere. I think I missed somewhere something. I don't know.
And again, if like CO2 retention is there, how to manage that. So these are the basic concepts of COPD ventilation. And these are the areas we tend to do mistakes as well.
Yeah. Okay. See what happened. This is what we were at, isn't it? 400 ml and 10. And what did we do? See, let us analyze now. What was the thing? So the minute ventilation is tidal volume into rate. So 400, so 4 liters is the minute ventilation. 10 is the respiratory rate. IE ratio is 1.2. 1:2. So one cycle time is 6 seconds. I time is 2 seconds and E time is 4 seconds. Okay. Now we had 4 seconds for 400 ml to come out, isn't it? We had 4 seconds for 400 ml to come out. What did we do? We made it into a minute ventilation of 500 into 16. Now almost 6 liters is the minute ventilation. Rate is 15. So IE ratio is 1:2. So one cycle time is 4 seconds. Now I time is 1.33 and E time is 2.66. So the question that I want you to think is, when 4 seconds was not capable of getting 400 ml out, how will 2.66 seconds get 500 ml out? It is never going to happen. Take my word, it's never going to happen. I have proved it to you mathematically now. See, look, one more situation here. What was the total amount of expiratory time we had in this cycle? 4 into 10, 40 seconds. What is the total expiratory time we had here? 15 into 2.66, 40 seconds. Both are having 40 seconds. When 4 liters cannot come out in 40 seconds, how 6 liters will come out in 40 seconds? It will never happen. So what you have to understand is that tidal volume, increase in tidal volume and rate is not going to bring down your carbon dioxide. I am amply sure that you would mathematically appreciate that it is correct. Any doubts on this?
No, sir.
Okay, I'll go. See, this is a exaggeration where the tidal volume is rate is 19 with a minute ventilation of 8 liters, 450 ml, only 410 ml is coming. There is some auto peep here, I have not drawn it properly. And we have an expiratory time of 2 seconds. When I make the rate as 8, the rate as 8 and the minute ventilation as 3.28 liters. See, look at, for 450 ml, I'm getting 470 ml. This is extreme. I'm just put this slide to convince you, once you reduce the rate, the amount of time per one total cycle time of 1 minute or per breath will be much higher. This should be around 8.4 seconds. If you make the rate as 8, this should be around 8.5 seconds. Then what has happened? More volume is coming out. The trapped volume is coming out. So from these 2 slides, my message to you is, one is volume is going to increase. Volume is going to increase the auto peep or the trapped volume. Rate is going to increase, because if you increase the rate, the total expiratory duration that is available for that 1 minute is not going to increase. I have proved to you mathematically. If you have any doubts on that slide, we will come back at the end of the discussion. But when I have shown you mathematically that when 400 ml cannot come out in 4 seconds, how 500 or 520 ml of whatever I've said will come out in 2.66 seconds, it won't come. Or if the minute ventilation of 4 liters doesn't come out in 40 seconds, how come 6 liters will come out in the same 40 seconds? It won't come. So it should be amply clear to you that tidal volume and rate are not 2 things which you should increase to decrease your PCO2 or the way you ventilate with your COPD patients. And this slide you see here, 400 ml, 4 seconds, dead space is 2 ml. Now I increase it to 450. This is getting overinflated and it's compressing my vasculature. A part of it is becoming dead space now. The dead space has increased to 3 ml per kg. So carbon dioxide will start increasing irrespective of the time. Now see here, I have increased it to rate to 15 and tidal volume to 500. See what has happened. This is totally compressed. The whole volume may become a dead space volume. So this is another thing that you have to factor in. If you increase the rate and your tidal volume, this is what happens to your vasculature. Once this gets totally occluded, the whole alveolar volume becomes a dead space ventilation. So your dead space increases Probably by decreasing the tidal volume to 350, I would be able to ventilate this guy better. This is the take-home message. And another thing is this leads to increased PVR and carpulmonary. So I hope that in the last 3 slides, the message is clear that you should never increase tidal volume or rate when you are ventilating a COPD patient. The rate should be around 12 to 15 and tidal volume should always be 6 to 7 mils per kg for a COPD patient. Another explanation is carbon dioxide is inversely proportional to effective alveolar ventilation. You see here, the dead space is 150 and you have a into 10 breaths is 1.5 liters. So effective alveolar ventilation is minute ventilation minus dead space ventilation is 2.5 because it was 2 ml per kg. Now it may be around 5 ml per kg. So what has happened here? The dead space is almost, dead space volume is 6 liters. The effective alveolar ventilation is only 1.51 liters. Obviously, your carbon dioxide will go up. Carbon dioxide will invariably go up. I have seen my junior colleagues, whenever you get a AVG from a COPD patient and carbon dioxide is more, they'll go and increase the tidal volume and the rate. It is not going to work. It will. You can go and check it up day in, day out. It will not work. And I have mathematically proved to you that it doesn't work. So what do we change? So this is a statement that should you remember. Carbon dioxide is inversely proportional to effective alveolar ventilation, and the dead space quantification at the bedside is very difficult. We generally accept 2 ml per kg as the standard and go with it. It may be much more when the trapped volume is huge, and if it compresses your vasculature, most of your alveolar volume also may add up to your dead space ventilation. So the bottom line is 6 to 7 ml because the inspiratory capacity is reduced, rate not more than 12 to 15, and low tidal volume will increase the PCO2, which is the price we pay for preventing dynamic hyperinflation. In fact, the literature suggests that dynamic hyperinflation is much larger than those of permissive hypercapnia. And this is the bottom line. Never ever in COPD ventilation try to correct your carbon dioxide with your ventilator. It is not possible. Once your pH becomes more than 7.25 or 7.3, that is the point when you have to stop looking at your carbon dioxide. Whatever the carbon dioxide is there, don't try to correct this. Because a lot of patients would be at a baseline carbon dioxide at 60, 70. Don't try to bring it down because its bicarb should be around 35, 36. Don't try to do this. Once the pH becomes all right, the ventilation in COPD ends. If you look at this example, this is a patient who should be allowed to be the way he is. Don't try to decrease this. This is the message I want you to carry home. This I've already shown you. So coming to mechanical ventilation now, there are 2 ways of mechanically ventilating. Look at this guy. A COPD guy, drowsy, looks dehydrated, BP 80/60, accessory muscle usage, pH of 7.92, PCO2 95, bilateral crepitations, bicarb is 35. In all other patients, I would say go and intubate. But these guys, because it is very, very difficult to wean and extubate, takes a long time. A 2-hour trial of a non-invasive ventilator can be tried. Non-invasive ventilator can be tried. Probably this guy is drowsy because carbon dioxide. He's tired. He's not able to generate the inspiratory pressures to push the volume in. If you just put him on a NIV, support him for a while, correct his dehydration, blood pressures may go up. See, this is what has happened. I put him on a pressure support of 12, PEEP of 5, fluid resuscitation. Now look, mentation is better, synchronizing well. After 1 hour, the AVG looks much, much better. So in a COPD patient, unless there is an impending or life-threatening hypoxemia, if the saturation is around 50, 60, probably this guy has to go in for a ventilator. His saturation is around 85. This patient can be given a trial of non-invasive ventilator. Another thing is, never think that NIV is a substitute for mechanical ventilation. No, there is a clear-cut indication that patients who can fit into NIV and patients who have to be intubated. As I said, life-threatening hypoxemia is one indication in a COPD to be intubated. See, after trial of 2 hours, if the patient is not, again, drowsy, not synchronizing well, pH has deteriorated, PCO2 has gone up, probably this guy requires an intubation. And if This guy comes with a life-threatening hypoxemia, no trial. Patient has to directly go for intubation. So this is how NIV, Anoop told me NIV has been extensively discussed. I just want you to remember 2-3 points, just 2-3 points. One is here EPAP or PEEP is 4, and when you say IPAP, it includes this. So when you change PEEP, this starts decreasing. So when you change PEEP from 4 to 6, IPAP has to be changed from 12 to 14. So this IPAP is in ventilators. If you had noticed, it is always pressure support above PEEP, pressure control above PEEP. It is not like they cut here. They could have done it like that. I don't know why the companies do and confuse all of us. So whenever you change EPAP, the pressure support level decreases if you don't change the IPAP. This is one point I want you to remember. So NIV is the gold standard, but it doesn't mean that it's a substitute, and patients can be put on NIV when there are indications for intubation. A few small suggestions here is when you post intubation, if the ventilator is not ready, if you are bagging, don't use large tidal volumes. That is, I have seen nurses, when the saturation goes up, they'll be pushing in 2 liters. The AMBU is 2 liter bag. They will empty 2 liters every time. And by the time you saturate the ventilator, probably the patient would be arrested, isn't it? And if the patient is paralyzed by relaxant, the experience says that it is better to keep 6 COPD patients for a day or 2 passive and medically correct the bronchospasm and then go in for a weaning and fill them adequately before induction. If the patient has a carpulmonary, a small dose of dobutamine or a dopamine would be ideal before intubation. These are small tips or tricks that you have to know to manage the COPD patients. So there are 2 ways, isn't it? One is passive, one is supported breath. So volume controlled, tidal volume should be 6. I have said tidal ratio and IE ratio. See, once we say this is fixed, that 6 to 7 ml and 12 to 15, the only thing that is available for us to do is increase the E time, In both the ventilations, only thing that we have is to increase the E time. Either in a passive ventilation, you can generally reduce this and keep the E time more. If you are looking at or increase the peak flows. If you keep the peak flows more, as I've shown you the bucket example, if the time is kept constant and if you open the tap more, the bucket fills faster. So if you keep the time shorter and increase the flow, the tidal volume is delivered much faster. So you can shorten the inspiratory time. So a peak flows of 60 to 90 liters can be accommodated in a COPD patient. Normally we use about 30 to 40 liters. More than that, there are studies to show us that it increases airway shear trauma. The epithelium are injured if you go more than 80 to 90 liters. So, or you can increase the expiratory time in pressure support by 2 things. I have repeatedly showed you that is important. One is by increasing the expiratory trigger sensitivity, which is at default 25 to more than 40 or 50. And second thing is increasing the rise time, which is nothing but increasing the flow. These flows are for very sick patients, and PEEP is always in a passive patient, not more than 5 to 6, and in a spontaneously breathing patient, maybe a PEEP of around 6 to 8 would be the maximum that we would use. Here, respiratory rate and IE ratio cannot be fixed by the clinician. So expiratory sensitivity and rise time adjustments you have to do. So we'll go now into numbers. So one thing is you have to increase the expiratory time. In a passive patient, it is very easy. You can generally set a E ratio of 1:3 or 1:4. Then how do you decide whether it is 1:3 or 1:4 or 1:5? Always when you change the IE ratio with a fixed tidal volume and a rate, check the plateau pressure. You can cut short the inspiratory time. Once the plateau pressure reaches around 26, 27 centimeters, that is the time when you have to give that much time. See, if you are starting at 1 second, say, cut down 0.9, 0.8, 0.7, 0.6. At 0.6 seconds, if the plateau pressure becomes 27 centimeters, from 20 to 27, if it shifts, that is the time, or that is the amount of time you have to give it for inspiration, and the rest you can leave it for expiration. Got my point? You fix the tidal volume. you fix the respiratory rate, check the plateau pressure. If the plateau pressure is 21, cut down the inspiratory time. Because you are cutting down the inspiratory time, the pressure is building faster, the pressure starts going up. Once the plateau pressure comes to 26, 27, you stop the decreasing of inspiratory time. That is the time required for inspiration. And if you cut down further, it will cause alveolar injury. The rest you can leave it to expiration. Generally, you can go up to 1:3 or 1:4, 1:5 is the ratio that we normally use for COPD ventilation. You just don't set it empirically, or you just set it at empirically, check back. 1:5, check. Plateau 1:6, check. Plateau is 31. You cut down to 1:5. Plateau becomes 27. Leave it at that. You can do it, but for that period of time, there would be an alveolar injury. It's better to go with a reduction of inspiratory time. This I've already discussed. So why the peak pressure goes and plateau pressure doesn't go up? Because most of the pressure is used up here. Most of the pressure is used up here. Look at the size of the arrow here. Only this much of pressure is transmitted to the alveoli. So we accept a very high PEEP, but the trans airway pressures are very low. This may be around 42 and this may be around 20. The trans airway pressure will be 25, 26. Because most of the pressure is used up, but plateau pressure should not rise above 27 centimeters of water. That is the bottom line you have to remember. So this is the peak flow calculation. As I've said, around 60 to 80 liters is what generally is required for most of the patients, but beyond 90, 100, there may be airway injury. So here, see, there are a lot of missed breaths. The peak flow was 30. I increased the peak flow to 90. Look at the number of missed breaths. Look at the arrows here. See, these arrows are not supported by breaths here. See here, no breath, no breath, no breath. Look here, what happened here? What actually happened here? When you increase the peak flow, that means you have increased the tap flow. So the tidal volume is going faster. Your bucket is filling faster. So the inspiratory time is shortened. The expiratory time is increased. So whenever you can shorten the inspiratory time by increasing the peak flows. In a passive breathing patient, either you can cut it down on your own by looking at your plateau pressure. Beyond that, you can also cut it down by increasing the peak pressures, because that delivers the tidal volume at a shorter time. But always check the plateau. If the plateau crosses 27, probably this may be high flow. Then you have to cut down to 80. That is the take-home message. You remember that. So now that we have understood, we'll just go with the numbers. Now you understand the rationale. So we set a FiO2 of 40% and we don't target a SpO2 of 9900, because they generally, when you see a COPD patient walking around the ward, sometimes his saturations will be 85, 86. So around 90 is what we target. Volume controlled ventilation, square wave. What is the tidal volumes you want to give? Why? What is the tidal volumes? Why? Because there is decreased inspiratory capacity and it will compress your vasculature, and the whole volume in the alveoli may become a dead space volume. So never ever use more than 7 mils or 6 mils is what you have to sit at. Respiratory rate, I've shown you 12 to 15. IE ratio is 1:3 or more, always looking at your plateau pressure. Plateau pressure is around 26, 27. Flow is 60 to 80. In sick occasions, around 80 to 100 is acceptable. As I've said.
Sir, can I just interrupt, sir?
Yeah.
The previous slide.
Yeah.
Persons are asking why like volume control, why can't it be pressure control?
So pressure control, the problem is when the pressure starts increasing, when the pressure, because the pressure is already high, the volume that you deliver may be very, very erratic. The volume delivered is not assured. In a COPD patient, volume delivered will be kind of, once the spasm increases, the tidal volume, which was 400, may become 200, 100. So there may be life-threatening acidosis and hypercarbia. It requires to be closely monitored. So pressure control can be done if you are very, very cautious at looking at your volumes. But I would say volume controlled ventilation where volume is assured would be a much better way to ventilate patients with COPD. But there is definitely no contraindication. If you are very careful and taking a lot of time spending, if you are a respiratory therapist, you can go and ventilate with pressure controlled ventilation. There is no problem. But as I said, volume fluctuates a lot. We have seen this happening. And another thing is trigger setting. Here, trigger setting can be as low as 0.5 centimeters also, or 0.5 liters, because there will be some auto peep. There won't be excessive triggering that would occur in a normal patient. The trigger is very, very minimal setting of trigger, and peep I have already said. And any increase in these pressures, you have to decrease the peep. You can allow the PAPs to go sometimes in a very severe asthmatic or a COPD. Initially, the pressures may be this, but the trans airway pressures will always be low. So in a spontaneously breathing patient, you have to set the pressure control to keep the tidal volume to 6 to 7. See, you have to control. If you can't control the tidal volume, irrespective of bringing it very, very low, or the patient is breathing very, very high, very restless, probably you have to sedate him. And if it doesn't fit on to sedation, probably you have to increase the sedation and go to some other mode of ventilation. So because this we cannot control, the tidal volume is controlled by the patient's effort. If the patient is on a 8 centimeter of pressure support generating more than this, probably, but the lung is the spasm is very, very bad, probably you may have to change the mode. This is a common question everybody asks me. If pressure support is very low, but the tidal volume is more, you have to sedate and see. If it doesn't work out, some other modes have to be tried, like NAVA, or sometimes keeping them passive. We cannot control the IE ratio and respiratory rate. This I have already told you. The only way to shorten your inspiratory time and increase the expiratory ratio is by the expiratory time sensitivity, trigger sensitivity and rise time. These states I have discussed extensively. I will show you once again. This is how it occurs. See, if I decrease this from 25 centimeters, 25% of the peak flow to 50, the inspiratory time is reduced and the expiratory time becomes more. See, expiratory trigger sensitivity, what you have to set. I'll show you in the next slide. This is the expiratory trigger sensitivity. By default, it is at 25%. In COPD patients, you can increase up to 50% because you can shorten the inspiratory time. By shortening the inspiratory time, you can keep the patient comfortable by increasing the rise time. What rise time means, I'll show you in the next slide. And see, this is what you should never do it in a COPD patient. It should be 0.5 centimeters or 1 centimeter, not more than that. This is a flow trigger. This is a pressure trigger. It should be 1 liter per minute. It should be the flow trigger. This is, see, this is the PEEP, what you set, and this is the pressure support. This pressure support setting is what controls your tidal volume. If your tidal volume is more than 6 or 7 mils for the predicted body weight, you should cut down this. This is how you do the pressure support ventilation. Only these 3 modes is where you concentrate once you set this. And this is the time. You can see once you change this, the TI, the inspiratory time starts decreasing. Then you can't do a plateau pressure here because there is no patient is spontaneously breathing. He is not going to just allow you to press the button and stop the flow, isn't it? It's not going to be possible. But most of the patients on pressure support will be a patient who are weaned in COPD. Probably the spasm would be not very severe. These are the 2 things we change. See, this is with a 25%. Look at the I time here, and I've changed it to 52%. Look at the I time here. Look at the expiratory time here. This is how you ventilate. And the other thing is you can change this. What is this? What it is this? This is nothing but increasing the peak flow. If you change the pressure ramp, this is what it means. See, the amount of pressure, the time it requires to reach the set pressure is much faster. This is the inspiratory. This is the time for the patient to finish his inspiratory breath. So the rest goes to the expiration. If this has a peak flow of 60 and if this has a peak flow of 40 liters, this is going to take a longer time to reach the set pressure. So the inspiration will be prolonged. It is nothing but increasing peak inspiratory flows. It has been mentioned as rise time in a pressure ventilation so that it gets confused. You can always say that or think that when I increase the pressurization of the circuit, how does the pressurization of the circuit occurs? Only by increasing the flow. That is what it means. This is given in your manual. You can go back and check. It is different for different ventilators. Sure. So you can say 20% of the slope, 30% of the slope, 40% of the slope, or the inspiratory time is how you set the rise time. For all of you, you can think that you are increasing the inspiratory flow rates, inspiratory peak flow rates. That is what you have to understand. It means by rise time. Sorry, I think Saneesh told me that it's closed. This slide I've already shown you. Just skip this slide. So we'll come to weaning. There are problems with weaning also. These guys are on steroids, relaxants, so myopathy is the issue. And when you are weaning, always consider the size of the tube, secretions, kinking, HME filters and all. So these are small factors, but it may hamper down the weaning. Other thing is, as I've already told you, these are some of the things you have to consider. Fever, pain, which increases the carbon dioxide production. This can be easily managed at the bedside. Whenever you are trying to wean, you see to it that the patient doesn't have fever, pain, and anxiety. If the patient has this, his PCO2 increases, and then you have to increase the amount of volume that it requires to get the carbon dioxide out. Role of tracheostomy is uncertain, but weaning can be done with pressure support to a spontaneous breathing trial. In a very, very difficult cases, you can, if the patient is not weaning after a few days or 10 days or 6 days, then you feel that there is a fixed component. The patient is a respiratory cripple, was on NIV before, then you can extubate and put him on NIV. There is a great evidence, especially in COPD patients, you can extubate the patients electively for NIV ventilation. In a carpulmonale, a small inotrope or a small dose of a dobutamine before weaning or during weaning helps in extubation. We have seen this. And before extubation, a small dose of diuretic and keeping the lungs dry on the day of extubation generally works in a COPD patient. The only difference between asthma and COPD is there is decreased collapsibility in asthma. It is filled up with inflammation or a mucus. It doesn't collapse. So the only difference is you have to use minimal PEEP. The amount of PEEP that you use should be very, very less, never more than 5 centimeters in a spontaneously breathing patient. In a passive patient, probably this is the one condition where 2-3 centimeters of PEEP should be okay, but the rest all the things hold the way I've told you. And the rate can be little bit lower than COPD ventilation to 8 to 10. So this is, if anybody smokers are there, I would advise you to quit smoking because COPD is a bad disease to have. Thank you.
Okay, sir. That was a wonderful description of the rationale behind ventilator setting in a COPD patient. I think the key principles are already delivered. We'll have 1 or 2 case scenarios to make sure that you got the message clearly, because as sir, like we discussed yesterday, actually we are talking to a virtual audience. Okay, we assume our feedback from most of the people, but who are actually volunteering to give the feedback through the chat or coming over to our interactive session. Okay, basically COPD, we are targeting CO2 washout, but how much CO2 washout? Generally, we don't depend on a particular rate of CO2 washout. Our target is pH. Okay, we don't try to bring down 90 to a normal CO2 of 40. We look at the pH and just check whether our CO2 washout rate is reassuring or not. So there were some doubts during the lecture. One question was how much CO2 washout in NIV is reassuring to decide whether to go ahead with NIV or to switch over to investment.
In NIV, first 2 hours assessment, I would say if the carbon dioxide is not increasing, patient is comfortable, probably you can continue. And there also the principle is only targeting pH. Sometimes depending upon the medical therapy, how it works, how fast you are able to break the bronchospasm, probably a decrease of 5-10 millimeters of mercury could be all right. But sometimes they are quite resistant for the first or second day. We have seen this happening. If the patient is syncing with the ventilator well, not fighting the ventilator, if the carbon dioxide is stable, pH are around more than 7.2, I would go with an IV. Mentation is another thing. Is reasonably capable of managing the airway, we would leave it at that. So putting a number and saying this much has to come doesn't work. In numbers, it is, you have to individually look at each patient.
Okay, so that response, actually, the key message is we don't go by the numbers. We actually go by the clinical improvement and see how patient sets in with his breathlessness or respiratory distress. That is an indication that our NIV trial is working. If patient keeps symptomatically worsening, then we have to go ahead with the next option. Okay. So there was a doubt regarding ramp and rise time. Is there any difference between these two?
No, both are same. The rate ramp is the same one I showed. No, I showed you 3 ramps. The one inclination which is at 90 degrees, the angle of 90 degrees is the shortest. And when the angle goes to 40, 50 degrees, it takes more time. That is ramp. And when it is given in percentages, we call it as 90 degrees, 60 degrees, 50, or percentage of inspiratory time. It for all of you, remember rise time is peak flows. If you increase the rise time, peak flows are increasing. There will be a table in your manual for the ventilator which says what is the flow at each ramp. You can check it up or call the application specialist. When you convert it into peak flows, your understanding becomes much simpler.
And there were some queries regarding inverse ratio ventilation. I think for oxygenation, we are actually concerned with the inspiratory time, where we are going for refractory hypoxemia, we go for inverse ratio ventilation. And when we deal with COPD, CO2 washout, actually our key point is to give as much expiratory time as possible. So that is the key message.
In fact, you can say it is not to be done, no? That's what Saneesh is telling.
Yeah. So rather than stressing on the tidal volume wind ventilation concept, the maximum time if we can give to the exhalation phase, expiration phase, we can expect more CO2 washout rather than playing around with the perceived alveolar ventilation, wind ventilation and all. We have already discussed with specific scenarios where actually when the wind ventilation rises from 5 liters to 7.5 liters, actually the expiratory time is compromised, the dead space ventilation goes up, our actual alveolar ventilation is compromised, and there is not enough time for our CO2 washout. And there was one query regarding auto PEEP, actually when we should get worried, what is the threshold?
In a spontaneously breathing patient, when you start increasing the PEEP, when the number of triggered breaths or its rate starts settling down, that is good and fine. When the patient starts increasing the work of breathing and starts increasing the pressures or increasing the effort to breathe, that is when it is going and hitting your alveolar this thing. So generally what I would advise you is, as a guideline, around start with 4 and max is 8 is what you go on a spontaneous ventilation. We rarely go beyond that. So when you keep on increasing, keep watching the patient. When the as long as the patient is comfortable, decreasing the inspiratory rate and the tidal volume because it is supporting his inspiration, probably it is working well, because you can't do a plateau pressure on a spontaneously breathing patient. At that range, I would say you are very comfortable.
Okay. Om Prakash Gode, your mic is on. You can go ahead with your question. You can introduce yourself. Yeah, you can introduce yourself and go ahead.
So I don't have any questions. I raise hand for the next case scenario.
Okay, fine. So
sorry, sir.
Keep waiting. Okay, no problem.
Okay, go ahead, Saneesh.
Yeah, okay. So we'll have a discussion on a few scenarios. Okay, you can stay with us. So I'll start sharing my slides, sir.
Yeah, please.
Is it visible, sir?
Yeah, visible for me.
Okay, fine. So, Dr. Om Prakash, you are with us?
Yes, sir. Yeah.
Yeah, we'll start with a small question. A respiratory therapist is determining the tubing compliance of a ventilator before use. Okay. The volume of 100 ml delivers a pressure of 33 centimeters of water. What is the compliance of the circuit?
Compliance is, sir, radial volume divided by the pressure.
Yeah,
Pressure
compliance is
divided by
actually the volume divided
pressure.
delta V by delta P. Okay.
Yes, sir.
Yeah, here actually 100
100
ml
by
causes a rise in pressure of 33
33. The
centimeters
compliance
of
will be
water.
around 3 centimeter of water.
Yeah, 3 ml per centimeters of water. Okay.
Water.
So just to give you an idea what compliance means. Compliance is basically distensibility. Okay.
Yes.
Because I need you to understand this concept clearly because we are going ahead with another concept. Fine. So you can take this question also. In pressure support ventilation, a patient's peak flow is 50 liters per minute. Okay.
Okay, sir.
At what flow level will the inspiration end if the ventilator has 25% flow cycle criteria? The expiratory trigger sensitivity that we mentioned before is 25%.
12.5 liter per minute.
Yeah.
Good.
The patient.
Exactly. Yeah.
If
So
it is
from
50%,
50, pardon? Yeah. Go
if we
ahead, sir.
change it to 50%, when will it?
25 liters, sir.
So it is moving towards the inspiratory side, isn't it?
Yeah. Yes, sir. Yeah.
So you have shortened the inspiratory time.
Yes, sir.
So you may have to increase the peak flow.
To get more expiration.
No, to make the patient more comfortable, isn't it?
More comfortable, yeah.
So you increase the rise time now.
Okay, sir.
So then you give more time for expiration. Yes, go ahead, Saneesh.
Yeah. Okay. So you're getting the concept, no? So basically, initially we set at 25%. So we had the inspiratory time from 50 liters per minute coming down up to 12.5. So once we reset or change the expiratory trigger sensitivity to 50%, then by the time 50 liters per minute becomes 25 liters per minute, then cycling occurs. Okay. So we'll have less of inspiration time and more importantly, more of exhalation time.
Expiration. Yeah.
Okay, fine. Anybody else would like to take the next scenario? Because basically through our interaction, we can make our concepts across. Okay. Dr. Guru Prasad, I think you can go ahead.
Yes, sir.
Okay, I'll give you the third question. You ready?
Yes, sir.
Can you introduce yourself? I think you had come for interaction before also, I believe.
Yes, sir. I am Dr. Guru Prasad,
Okay.
an intensivist in Gadag, Karnataka.
Okay, okay.
Hey, hi, Guru. How are you?
Fine, sir. Thank you, sir. Fine, fine.
Good.
Okay.
Yeah.
Okay, fine. This is another practical scenario. A patient on pressure support ventilation has an endotracheal tube cuff that is not inflated, preventing the ventilator from reaching the flow cycle criterion to end the inspiration. So now what will terminate the inspiration?
Pressure support ventilation, no, sir.
Yeah, this is on pressure support ventilation. Usually, depending on our expiratory trigger sensitivity, when the flow reaches that particular value, then it cycles.
But in pressure support, either the trigger as well as the cycling is controlled by the patient.
Cycling is generally flow determined, generally.
Yes. But in a pressure support ventilation, it is a the patient who can control the cycling.
Patient actually can initiate or trigger the ventilation. Okay,
Yes.
trigger the breath cycle. Then actually with the pressure support, it goes to a set pressure support and that limits the breath.
Breath, yeah.
Okay. Then the cycling usually occurs with our expiratory trigger sensitivity. That's
Correct.
why we indirectly manipulate the inspiratory time. That is what we were trying to explain throughout.
Yes.
Okay. Suppose we had a hurdle in between, the cuff was not inflated and the flow is not coming to our say 25% set value. It takes long time.
No, actually, but still, if you if the flow is set, if the flow is set, the ventilator will try to deliver that much of flow, no, sir?
Yeah. So it's not coming down to that set trigger sensitivity level.
Yeah. Then time should decide on the inspiration.
Yeah, yes, exactly. So what we call it as TI max. So ventilator and pressure support ventilation, machine will wait up to a particular time and then cycle to the exhalation. So that will become the determinant in this case.
Yes.
Okay, fine. This is a common scenario. So next case-based scenario, we have a COPD patient intubated on ventilator. Okay. When you started on ventilation, you find the machine gives the value of resistance as 20 centimeters of water and compliance 47 mLs per centimeters of water.
Okay.
So what exactly you mean you will benefit from these numbers, because we are ventilating a COPD patient?
Actually, here because it's a COPD is a resistance problem. The initial flow is takes to overcome the resistance.
Okay. So most of the pressure used in driving the lung inflated will be dissipated in overcoming the resistance.
Resistance. Yes.
So the key point we are delivering now is we concentrate on the expiratory time.
Yes, sir.
So our discussion will boil down to our key points.
Yes.
Suppose the patient has a height of 160 centimeters. What is the predicted body weight? The other day we had given a rough estimate.
Minus 100. Minus
Minus
that
100.
is 60.
So we will take it as 60. Okay. Your ICU is as good as the number of measuring tapes you have. You remember,
yes,
sir, telling?
Yes, sir. Yes, sir.
Okay, fine. So the JR set the ventilator mode like this. Started on volume control mode, assist volume control mode. Okay. FiO2 of 40%. Tidal volume of 4 mLs per kg, 7 mLs per kg, so roughly 420 mLs per kg.
Yes, sir. Yes, sir.
He or she has kept 4 centimeters of water as PEEP.
Yes.
Right, respiratory rate of 15.
Okay.
I ratio 1:3.
Yes, sir.
Peak pressure 33 and plateau pressure of 13.
Yes.
Okay. So, are you happy with this setting?
I think. No, actually, happy with the setting means I want to see. I want to see the ABG exactly. What is it?
Okay. Okay, fine. So before that, as being the first case, I'll explain.
Yes, sir.
So we have explained regarding the time constant concept, right?
Yes, sir.
So we need at least 3 time constant duration as our exhalation time.
Exhalation.
Okay. So your expected time constant is our resistance into compliance. Okay.
Yes.
So this is what I expected when I said when you get these values, are you interested? Because we are ventilating a COPD patient. So you multiply resistance, the value of 20, 47 mLs per centimeters of water will convert to liters. So 0.047. Okay.
Yes, sir.
So in your take calculator, now it's already calculated 0.94 seconds is our time constant. Okay. Almost 1 second.
1 second. So into 3.
So 3 time constants is
3
almost
seconds.
3 seconds.
Yes, sir.
Okay.
Yes,
Now go back to our setting. Our setting says respiratory rate of 15.
Okay,
That
sir.
means
Every
one
4
breath
seconds.
cycle is
4 seconds.
4 seconds.
Yes, sir.
If we divide into 1:3, so 1/4 will be inspiration, 3/4 will be
Expiration.
expiration. Fine.
Yeah.
So what we got is 1 second for inspiration and 3 seconds for expiration.
Yes, sir.
So now you look back at these values. Are you happy with the setting now? Do you believe that you are giving enough time for exhalation?
Yes, sir.
Yeah.
1:3. Yeah.
So you check an ABG.
Yes.
This is the blood gas. pH of 7.32, PO2 of 70, PCO2 72.
Saneesh, people are saying something is there on the screen and screen is not visible. Some white.
No build effects. No build.
No build effects is coming on the screen.
1 second. I'll stop share and restart.
Yeah. Yeah, it's the no, again it came.
Again?
Again it has come. Just keep the screen half. When you kept the screen half, it didn't come.
Okay, 1 minute. Then I'll open the PowerPoint files. And then.
Yeah, it's better this way.
Yeah,
Yeah.
I can see, sir.
Yeah. No, it's gone, Saneesh.
Yeah, I'll take.
Chandrasekhar, sir.
Yeah.
Yeah, that patient whom I showed about the spacer got extubated yesterday, sir. Got
Good.
well.
Congratulations.
Thank you, sir. Thank you, sir. The MDI only worked better than a nebulizer for that patient.
Yeah, yeah. The delivery is much better there.
Yes, sir. Yes, sir.
We have discussed this before also.
Yes, sir. Yes, sir. And even the auto trigger helped me, sir. That lecture helped me 2 days back.
Okay.
The patient was triggering repeatedly.
Okay.
In spite of giving 2-3 doses of paralysis, also patient was triggering. And I realized that the pulmonary edema fluid was causing the trigger, sir.
Okay.
The movement of the pulmonary edema fluid was triggering the ventilator. So once suction was done, then again that flow trigger, auto trigger went off.
Okay. Good.
Your lectures are helping us a lot, sir.
Okay. Good.
Okay, so even this scenario was prepared by Chandrasekhar sir only. Okay. So now you can see these ABG values.
Yes, sir. Yes, sir.
Okay. How about this ABG?
I'm quite happy, sir. Actually.
Okay. So pH is fine.
Yes,
almost accepted.
I'll accept 72 PCO2.
PaO2 70, slightly on lesser side, but it's okay.
Above 60 is okay.
72. Bicarb 28. So maybe a chronic element is there. So he must be tolerating a higher PCO2.
Yes.
Okay. So as long as
come in, Saneesh, one. See, I want the junior doctors to remember there are two things which shows the patient is a chronic COPD or not. One is hematocrit. Second thing is bicarbs. When you get a AVG, if the bicarbs are around 30-35 and the hematocrit is around 55-60, because it should tell you that this guy is a chronic COPD. That is one information you have to know, and that gives a lot of thought for how to ventilate, how much time you may take. So that is two things I forgot to tell you during the lecture. Just now when I saw the bicarb, it struck me. So you can remember that.
Okay, fine. So the next question is, do you want to change anything? This is the ABG. This is our ventilation setting. So going by our theory or what we have been telling, this is accepted.
If I want to little more improve the pH, at the most, I would like to decrease the respiratory rate to about 12 or 13. That's also.
The other thing, I think, if you remember, actually ventilation is not the one which is going to cure your primary disease. So you ensure
nebulization.
What caused the exacerbation. If it is sepsis control.
Okay.
Anything else, then you control that.
Bronchodilators.
Bronchodilators, steroid antibiotics, or pulmonary toileting, chest physiotherapy. So ventilator cannot replace any of these things.
Correct.
Ventilation is just supporting so that our other measures work. So once you see this, I think a good judgment is you don't want to change much, play around much. You keep observing and see for the clinical improvement. And then you can, depending on the clinical scenario as it unfolds, you can change the scenarios.
Okay. Okay, sir.
Fine. Thank you. Anybody else volunteering for the next case scenario? Srilekha Bharat, you are allowed to talk. Just introduce yourself.
Hello, sir. This is Dr. Srilekha doing DM in Tata Memorial Hospital.
Where? Which place?
Tata Memorial Hospital, sir.
Oh, okay, fine. So we'll go to the next scenario.
Yes, sir.
1 minute. Okay, again, a COPD patient intubated on ventilation. The resident has kept the settings like this. Okay. Volume control mode, FiO2 40%, tidal volume of around 520, PEEP of 4, respiratory rate 15, IE ratio 1:3. Okay, but here our peak pressure is 32. On pressing inspiratory hold, we get a plateau pressure of 12. Okay, so monitor gives a resistance value of 20 and compliance of 75.
Yes, sir.
So now the question is, are you happy with this?
The tidal volume is very. First of all, the time constant is 4.5 seconds, but our expiratory time is only 3 seconds.
Okay.
So we need at least 4.5 seconds for the expiration to happen. So probably the expiration is not happening completely. That's why it is adding up, and also the tidal volume is slightly high.
Yeah, okay. So that's a key take-home point we would like you all to take from this particular session. Okay, we concentrate more on the expiratory time. Expiratory time, we expect it to be anything more than 3 times the time constant. Okay, so this is the ABG you are getting, a pH of 7.2, PaO2 of 70, and PCO2 of 72, bicarb of 28. What change you would like to make?
I'll reduce the respiratory rate to 12 or 13 so that the expiratory time increases. I think I should reduce it to 10. Then the total time will become 6 seconds. And when based on the IE ratio, the expiratory time will increase further.
So 6 seconds, how much will be the expiratory time?
Expiratory time will be 3
1/4
by
will be
4.
inspiration, so 1.5 inspiration time, and 4.5 will be exhalation time.
So
Okay.
it will.
Okay. Any other means to give more in exhalation time?
I can increase the IE ratio to 1:4.
Yes, you can straight away increase IE ratio to 1:4.
Because the plateau is just 12. So IE ratio can go up to 1.4, 1.5, isn't it? That also is an option.
Yes,
Okay.
sir.
So as we mentioned, the more, the lesser we make inspiratory time, plateau pressure might go up. So you can go have a cutoff when the plateau pressure reaches maybe 25, 27, and then you don't reduce the inspiratory time beyond that. Okay.
Yes, sir.
So one more scenario. This is a patient on pressure support weaning, patient on ventilator day 6. Okay. The FaO2 is 40%. Pressure support over PEEP is 12. PEEP we have kept as 6. Expiratory trigger sensitivity 25% and rise time of 20%. Patient is currently breathing at 26 per minute and is restless, not comfortable. So what you would like to change?
I would increase the rise time and decrease the expiratory trigger sensitivity.
Decrease ETS means?
Uh,
From 25, which value you switch to?
12.5%.
The more, if you reduce the ETS,
then
actually you are giving more inspiration.
More
time.
inspiration, yes, sorry. So I would increase the ETS to 50%.
Yeah,
Yes.
so we will try to get the cycle, breath cycle cycled earlier.
Earlier,
Okay, reduce the inspiratory time, more of exhalation time. That is indirectly we can manipulate. Okay, so pressure support is from 12 to 10, ETS probably to 50, rise time to 40%. Okay, then if patient is still restless, it is still tachypneic 30 per minute and not comfortable on this pressure support. So what do you do next?
Sedate the patient and try to maintain a lower respiratory rate. And if it's still not possible, then sedate the patient further, use some other agent, and change the mode of ventilation.
Yeah, that indirectly tells you that patient is not ready right now for a pressure support weaning.
Yes.
Probably the background pathology curing or handling will take some more time. So we have to be patient, probably go back to plan B and settle down with the pressure control mode, sedation, maintain sedation analgesia, continue with our bronchodilators, antisepsis management and other bundles. And then probably when the condition settles, again attempt another pressure support weaning. Okay.
Pressure control mode or volume control?
Yeah,
Like
that is another thing. See, basically, we need to monitor the values. Pressure control mode definitely in COPD, when the bronchospasm is there, the lungs are not good, your volume is not assured. So volume control mode may be better, but pressure control mode, as long as you are watching the monitored values, it's fine. And we have other modes like pressure control, volume guaranteed mode, or APRV modes that we'll discuss when we discuss the advanced modes. Okay.
yes.
So critical care is all about close monitoring. It's not about setting something and then seeing the patient next day, right?
Yes.
Okay, so these are the messages generally we wanted to deliver during this session. Anything else?
Now the take home is never try to manipulate the tidal volume and the rate. You keep it low. The only thing you have to manipulate is the expiratory and inspiratory times. That is the take home message that I want all of you to carry home. If any doubts are there, you can put it into the groups. We will try to discuss when we have the discussion on next Tuesday. The whole day will be dedicated to only discussing the case scenarios. And next Monday, we will be discussing weaning.
Okay, so
Yes,
we can use you can have the best use of this academic platform. Chandrasekhar sir will be with us. So any doubt or any new points you want to add or new points you want to discuss, you can inform us through our Facebook page or our WhatsApp or Telegram groups. For your information, we are gradually switching over to Telegram group for our communication, because it's very difficult to manage 6-7 WhatsApp groups, because there is overwhelming response from our attendees regarding, though we are segregating into anesthesia stream and critical care stream and other general stream, it's becoming more and more tedious for us. So we'll be switching over to Telegram groups, because we can accommodate more numbers in a single group. Okay, so this is the schedule for the remaining part of this week. Wednesday, we'll have clinical nutrition by Dr. Anoop. Thursday, we'll have a faculty from United States, University of Alabama, Birmingham. He'll speak on ICU care bundles. Okay. Friday, we'll have a talk on the snakebite management from team led by Dr. Kumar from Calicut Medical College, Dr. Anoop, and hepatologist Mr. Vivek Sharma and Mr. Jose Lewis will be joining. Saturday onwards, we'll have a separate session for anesthesia stream, because people are interested in anesthesia webinars. So we'll start weekly once. On Saturdays, we'll have a program anesthesia based, and this week we'll be starting with a panel discussion on diabetes mellitus and anesthesia. One change we are planning to bring in is, again, this will be simulation based, case scenario based discussion, and we'll have another guest specialist in diabetes and anesthesia. We are getting one diabetologist specialist to give endocrinologist viewpoint what happens in the perioperative management. Especially we have to deal with the newer drugs, newer modalities with the diabetes. Okay, sir, shall we wind up the session today?
Yeah, thank you, Saneesh. Meet you next Monday.
It's been a wonderful session, and more people are volunteering for our interactive session. That we are very happy about that. Make use of this platform. So anything you want to clarify, Tuesday we'll have full session on interactive session. So you can come out with your points or small things we can add depending on your feedback. Looking forward to meet you in the further sessions of mechanical ventilation webinar. It's goodbye from all of us here.
Yeah, good night.
Thank you. Nice.